Diagnosis of leukemia. Diagnosis is usually based on repeated complete blood counts and a bone marrow examination following observations of the symptoms. Sometimes, blood tests may not show that a person has leukemia, especially in the early stages of the disease or during remission. 2. A lymph node biopsy can be performed to diagnose certain types of leukemia in certain situations. 3. Following diagnosis, blood chemistry tests can be used to determine the degree of liver and kidney damage or the effects of chemotherapy on the person. 4. When concerns arise about other damages due to leukemia, doctors may use an X-ray, MRI, or ultrasound. 5. These can potentially show leukemia's effects on such body parts as bones, X-ray, the brain, MRI, or the kidneys, spleen, and liver, ultrasound. 6. CT scans can be used to check lymph nodes in the chest, though this is uncommon. Despite the use of these methods to diagnose whether or not a person has leukemia, many people have not been diagnosed because many of the symptoms are vague, nonspecific, and can refer to other diseases. For this reason, the American Cancer Society estimates that at least 1/5 of the people with leukemia have not yet been diagnosed. Treatment. Most forms of leukemia are treated with pharmaceutical medication, typically combined into a multi-drug chemotherapy regimen. Some are also treated with radiation therapy. In some cases, a bone marrow transplant is effective. 1. Acute lymphoblastic. Management of all is directed towards control of bone marrow and systemic, whole body, disease. Additionally, treatment must prevent leukemic cells from spreading to other sites, particularly the central nervous system, CNS, e.g. monthly lumbar punctures. In general, all treatment is divided into several phases: induction chemotherapy to bring about bone marrow remission. For adults, standard induction plans include 1. Prednisone, 1. Vincristine, 2. Anthracycline drug. 3. Other drug plans may include L-asparaginase or cyclophosphamide. 4. For children with low risk, all standard therapy usually consists of 3 drugs: prednisone, L-asparaginase, and vincristine, for the first month of treatment. Consolidation therapy or intensification therapy, to eliminate any remaining leukemia cells. There are many different approaches to consolidation, but it is typically a high-dose, multi-drug treatment that is undertaken for a few months. People with low to average risk all receive therapy with antimetabolite drugs such as methotrexate and 6-mercaptopurine, 6-MP. People who are high risk receive higher drug doses of these drugs, plus additional drugs. CNS prophylaxis, preventive therapy, to stop the cancer from spreading to the brain and nervous system in high-risk people. Standard prophylaxis may include radiation of the head and or drugs delivered directly into the spine. Maintenance treatments with chemotherapeutic drugs to prevent disease recurrence once remission has been achieved. Maintenance therapy usually involves lower drug doses, and may continue for up to 3 years. Alternatively, allogeneic bone marrow transplantation may be appropriate for high-risk or relapsed people. Treatment of chronic lymphocytic leukemia. Decision to treat. Hematologists base CLL treatment on both the stage and symptoms of the individual person. A large group of people with CLL have low-grade disease, which does not benefit from treatment. Individuals with CLL-related complications or more advanced disease often benefit from treatment. In general, the indications for treatment are falling hemoglobin or platelet count, progression to a later stage of disease, painful, disease-related overgrowth of lymph nodes or spleen, an increase in the rate. Treatment approach. For most people with CLL, it is incurable by present treatments, so treatment is directed towards suppressing the disease for many years, rather than totally and permanently eliminating it. The primary chemotherapeutic plan is 1. Combination chemotherapy with chlorambucil or cyclophosphamide, plus 2 corticosteroids such as prednisone or prednisolone. The use of a corticosteroid has the additional benefit of suppressing some related autoimmune diseases, such as immunohemolytic anemia or immune-mediated thrombocytopenia. In resistant cases, single-agent treatments with nucleoside drugs such, 1 fludarabine, 2 pentostatin, 1 cladribine may be successful. 2 younger and healthier people may choose allogeneic or autologous bone marrow transplantation in the hope of a permanent cure. Treatment of acute myelogenous. Many different anti-cancer drugs are effective for the treatment of AML. Treatments vary somewhat according to the age of the person and according to the specific subtype of AML. Overall, the strategy is to control bone marrow and systemic, whole body, disease, while offering specific treatment for the central nervous system, CNS, if involved. 1 Combinations of drugs for the initial, induction phase of chemotherapy. Such combination chemotherapy usually offers the benefits of early remission and a lower risk of disease resistance. 2 Consolidation and maintenance treatments are intended to prevent disease recurrence. Consolidation treatment often entails a repetition of induction chemotherapy or the intensification chemotherapy with additional drugs. 3 By contrast, maintenance treatment involves drug doses that are lower than those administered during the induction phase. Treatment of chronic myelogenous leukemia. 1 Imatinib, Gleevec, therapy. Compared to most anti-cancer drugs, it has relatively few side effects and can be taken orally at home. With this drug, more than 90% of people will be able to keep the disease in check for at least 5 years, so that CML becomes a chronic, manageable condition. 2 In a more advanced, uncontrolled state, when the person cannot tolerate imatinib, or if the person wishes to attempt a permanent cure, then an allogeneic bone marrow transplantation may be performed. This procedure involves high-dose chemotherapy and radiation followed by infusion of bone marrow from a compatible donor. Approximately 30% of people die from this procedure. Treatment of hairy cell leukemia. Decision to treat. People with hairy cell leukemia who are symptom-free typically do not receive immediate treatment. Treatment is generally considered necessary when the person shows signs and symptoms such as low blood cell counts, example infection-fighting neutrophil count below 1.0 k/L, frequent infections, unexplained bruises, anemia, or fatigue that is significant enough to disrupt the person's everyday life. Typical treatment approach: people who need treatment. 1 week of cladribine, given daily by intravenous infusion or a simple injection under the skin. 2 6 months of pentostatin, given every 4 weeks by intravenous infusion. In most cases, 1 round of treatment will produce a prolonged remission. 3 other treatments include rituximab infusion or self-injection with interferon alpha. 4 In limited cases, the person may benefit from splenectomy, removal of the spleen. These treatments are not typically given as the first treatment because their success rates are lower than cladribine or pentostatin. Treatment of T-cell pro-lymphocytic leukemia. Most people with T-cell pro-lymphocytic leukemia, a rare and aggressive leukemia with a median survival of less than 1 year, require immediate treatment. T-cell pro-lymphocytic leukemia is difficult to treat, and it does not respond to most available chemotherapeutic drugs. Many different treatments have been attempted, with limited success in certain people: purine analogues, pentostatin, fludarabine, cladribine, chlorambucil, and various forms of combination chemotherapy. Cyclophosphamide, doxorubicin, vincristine, prednisone CHOP, cyclophosphamide, vincristine, prednisone COP. Vincristine, doxorubicin, prednisone, etoposide, cyclophosphamide, bleomycin vapec-B. Alemtuzumab, Campathy, a monoclonal antibody that attacks white blood cells, has been used in treatment with greater success than previous options. Some people who successfully respond to treatment also undergo stem cell transplantation to consolidate the response. Treatment of juvenile myelomonocytic leukemia. Treatment for juvenile myelomonocytic leukemia can include splenectomy, chemotherapy, and bone marrow transplantation. Prognosis. The success of treatment depends on the type of leukemia and the age of the person. Outcomes have improved in the developed world. The average 5-year survival rate is 61% in the United States. In children under 15, the 5-year survival rate is greater, 60 to 85%, depending on the type of leukemia. In children with acute leukemia who are cancer-free after 5 years, the cancer is unlikely to return. Outcomes depend on 5. Whether it is acute or chronic. 6. The specific abnormal white blood cell type. 7. The presence and severity of anemia or thrombocytopenia. 8. The degree of tissue abnormality. 9. The presence of metastasis and lymph node and bone marrow infiltration. 10. The availability of therapies and the skills of the healthcare team. 11. Treatment outcomes may be better when people are treated at larger centers with greater experience. Pregnancy. Leukemia is rarely associated with pregnancy, affecting only about 1 in 10,000 pregnant women. How it is handled depends primarily on the type of leukemia. Nearly all leukemias appearing in pregnant women are acute leukemias. Acute leukemias normally require prompt, aggressive treatment, despite significant risks of pregnancy loss and birth defects, especially if chemotherapy is given during the developmentally sensitive first trimester. Chronic myelogenous leukemia can be treated with relative safety at any time during pregnancy with interferon alpha hormones. Treatment for chronic lymphocytic leukemias, which are rare in pregnant women, can often be postponed until after the end of the pregnancy. 13. Stem cell transplant. Higher doses of chemotherapy can kill more cancer cells, but they'll wipe out healthy cells, too. That's when you might need stem cells from a donor to restore your supply. It can be risky because your body may reject the new cells, so it's mainly used when other treatments haven't worked. Sometimes, a stem cell transplant can cure the cancer, but it could also cause life-threatening damage to your immune system. 14. Targeted therapy. These medications are commonly used for chronic leukemia. They leave healthy cells alone and attack only cancer cells, which work differently. Tyrosine kinase inhibitors, TKIs, can basically cure CML, though you have to take them for life. For CLL, medicines called monoclonal antibodies mark cancer cells so your immune system can destroy them. And kinase inhibitors keep CLL cells from growing and dividing. 15. Gene therapy. CAR-T is a new kind of customized immunotherapy. For each dose, some of your white blood cells are removed and sent to a lab, where they get a new gene added that tells them to target and kill specific leukemia cells. These modified T cells then go back into your body to help kill the cancer. This treatment is only for people who are younger than 25 and have B-cell all that other treatments haven't worked on or that has come back. 16. Protect your brain and spine. This is something people with all are concerned about. While this type of cancer doesn't start in your central nervous system, at least half the time it ends up spreading there. To prevent that from happening, you get chemotherapy drugs directly into your spine. You may need more than one round of it. 17. Watch and wait. For many types of leukemia, you start treatment right away. But with CLL, it's common to hold off until you have symptoms. You still get regular checkups and routine tests to keep a close eye on things. Some people never have any issues and live out a normal life. You'll start treatment if your white blood cell levels jump, your platelets drop, or you get symptoms like swollen lymph nodes. 18. During treatment. Both leukemia and the treatments for it can lower your healthy blood cell count. To help your body get through the illness, you may need blood transfusions for anemia, antibiotics for infections, and platelet transfusions for problems with bleeding. Also, because your chances of an infection are greater, you and anyone who comes close to you need to wash your hands well and often. 19. Survival rates. Keep in mind that a lot goes into your personal outlook, including the type of leukemia you have, how advanced it is, and your overall health. Survival rates are averages, not your destiny. The 5-year relative survival rate for leukemia is about 60%. That means compared with every 10 people who don't have leukemia, on average, 6 people who do have it are still alive after 5 years.